Welcome to the VCA Voice Podcast. I'm your host, Dr. Marie Kerl. Join us as we dive into inspirational stories about our caring and capable associates and their commitment to guiding healing journeys for our patients. Our discussions explore the important ways VCA Animal Hospitals proactively supports the future of veterinary medicine through leading the industry in medical excellence and providing hometown care to our communities. On today's episode, I'm pleased to welcome Dr. Justin Allen and Maureen Mueller. Dr. Allen is a diplomate of the American College of Veterinary Internal Medicine in the specialty of cardiology, and Dr. Mueller is a diplomate of the American College of Veterinary Surgeons. They're both staff specialists at VCA West Los Angeles Animal Hospital in Los Angeles, California. Welcome to both of you.
Good morning, Marie.
Good morning.
So glad that you're here. And we have a ton of stuff to cover today because your programs are super exciting. But I do want to start off, and we'll start with Justin. Tell me a little bit about your journey in veterinary medicine and when you joined VCA.
Sure. I'm a farm kid from Illinois. And so I grew up around animals and always loved them. And I knew I wanted to do some kind of medicine. So when I went to college, it was between the human and the animal side, and eventually sort of went towards animal med. And I got to vet school and I had discovered there was such a thing as veterinary cardiology. I had no idea. Yeah, there were even specialists. And so, so that got me really excited and decided to pursue cardiology. Came out to Los Angeles back in 2006 to do my training with Dr. Ettinger here in West LA. And then went back to Chicago for one short year and then back to the Bay Area up north and then finally down here to LA.
And Maureen, how about you?
Yeah, it's kind of funny because I also grew up rural, a farm girl from Wisconsin. So kind of funny.
So we're representing the Midwest.
Yeah,
sure.
Yep.
Excellent.
Yep. And so I was unsure of what to do with my life. So I actually went to tech school first, went to 2-year tech school in Madison, and then found my way out to California. I was working as a technician, and then the new practice owner brought in a traveling surgeon. And I had started back to undergrad. And then that's kind of when I made the decision I wanted to be a surgeon. So I finished my bachelor's degree in San Bernardino, actually. And then with the whole my goal when I went back to vet school was to be a surgeon. And then did vet school at Purdue, and then Washington State was my internship. And then I did my residency in New York City. And then I joined West LA back in 2001, straight out of my residency, and have been here since.
Oh, excellent. So, Justin, as a veterinary cardiologist, what kinds of illnesses do you commonly see in practice?
Well, we see some mitral valve disease, and we also see mitral valve disease, and then there's some mitral valve disease thrown in there for variety. So dogs get mitral valve disease, and that's 95%, honestly, of what we see here in Los Angeles. I mean, we just have a predominantly small dog population. So we see, and small dogs get mitral valve disease to a greater severity than large breed dogs. Large breed dogs do get dilated cardiomyopathy sometimes, and we do see some of that. Cats, we do see a few cats, not as many as we do dogs, unfortunately, but we see cats, and they frequently have some kind of cardiomyopathy, which is a heart muscle disease. And so those are the common things that we deal with.
And Maureen, what about in small animal surgery, the common things that you see? And do you do all kinds of surgical practice, both soft tissue and orthopedics, or primarily one or the other?
Initially, I did both. So we always say soft tissue orthopedics. And then again, as it's just getting so much. So I always had a love for soft tissue anyway. And so like probably over the last 5 years, I stopped doing orthopedics. But on the orthopedic side, I always say the most common disease that we treat in this practice is cruciate rupture or ACL tear. But then like probably 80% of what I do is surgical oncology now.
Wow.
And then,
okay.
Then the rest is just, soft tissue, whatever that entails, from foreign bodies to that type of stuff. So I do, quite a bit of surgical oncology.
I've invited both of you on this episode because I really want to learn more about the innovations at VCA West Los Angeles Animal Hospital in interventional cardiology. So I know I have the right people to talk to about that. Justin, explain a little bit to me about some of the general concepts of veterinary interventional cardiology, and are there parallels in human healthcare?
Yeah, basically everything we do is based on things that have been developed for humans. So back in the 50s, they started to work with catheters and using catheters to access things that were previously inaccessible inside the heart. And so interventional cardiology in a large sense is basically catheter-based therapies for heart disease. And in the human side of things, that's the most people are familiar with are coronary stents. So that's when you got a blockage in one of your coronary arteries, and instead of having open heart valve or surgical repair or bypass, they'll put a stent in through your leg, through the vein or the artery in your leg. And that's similar to what we do. So we use catheters and access the veins and arteries in the body to deliver devices to the cardiovascular system or to fix things that are going wrong in there. In a little broader sense, where Maureen comes in, there are some sort of hybrid procedures where we need surgical access to things that we can't access just with a catheter.
You were instrumental in starting the service at VCA West LA. What can you share about starting this kind of a service from the ground up, and how unusual is it to offer these procedures outside of a university-based hospital?
It's pretty unusual just because of the equipment and the expertise that's necessary and the team that's actually necessary to do these kind of procedures. So to do interventional cardiology, at minimum, you need some type of moving X-ray that we call a fluoroscopy. And so that allows us to see the heart beating in real time as sort of a moving X-ray image. But it's sort of expanded beyond that recently. And so now transesophageal echocardiography is a major component of almost everything we do, especially the more advanced procedures, because you can see inside the heart. So the X-ray just shows you the outside of things. The transesophageal echo shows you a real-time three-dimensional image inside the heart, which is really crucial when you're trying to access little things inside. And so you need that. And for some procedures that are more complicated, you need a transesophageal echo, you need an echocardiographer that's acquiring those images. You need the C-arm, you need an anesthesia tech, so you don't have to also pay attention to that while you're trying to do your job. And then you need one, two, or even three people at the table working the different devices and catheters. If you're going to start a program, it's a bit of a hill, because there's a lot of equipment that you need to acquire just to start doing the more basic common procedures. And then you can use that to build as you go. But it's a question of obtaining the right people, the right space, and the right equipment, which does unfortunately take a little bit of capital and some time. So you can't do that at every practice.
Tell me a little bit about the main procedures you've introduced, and when did you start offering them?
Yeah, so they didn't offer interventional cardiology here, which is one of the reasons that they brought me in back 9 years ago. And so the most common procedures that we do in interventional cardiology are going to be pacemaker implantation, PDA occlusion, and pulmonic stenosis balloon valvuloplasty. So pacemakers go into dogs that have heart rates that are way too slow. PDAs are a congenital heart disease, so they're a heart disease that dogs are born with, where there's an abnormal vessel there that needs to be closed, or they'll go into heart failure. So we basically insert a plug, a fancy plug inside the vessel to close it off from the inside. And the pulmonic stenosis is a narrowing of an artery that should be open that takes blood to the lungs. And so you can blow up a balloon and open that artery. Those are the main three things that we do, the most common procedures. And those are fairly simple, and you can start with those. And we started doing those right away. There are some other rarer sort of congenital heart diseases that you can treat. But as we progressed, we started doing a procedure called left atrial decompression. I want to say about 7 years ago now, probably a little over 6 years ago, which is a treatment for congestive heart failure in dogs. So we often do it in dogs with mitral valve disease. And as I previously mentioned, that's the number one disease we see. So that's become one of the more common procedures that we do to alleviate heart failure in dogs.
Okay.
And more recently, I think the newest procedure that we do on a semi-routine basis is a transcatheter edge-to-edge repair of the mitral valve. And that's the one that we need Maureen for. And that's a clip basically called a V-clamp that actually attaches the mitral valves together and that reduces the leak.
And just in case our listeners are curious, can you define PDA?
Patent ductus arteriosus. So it's a normal fetal vessel that connects the aorta to the pulmonary artery because your mom's breathing for you. And then when you come out, take your first breath of air, that PDA is supposed to close. So that way you can breathe for yourself.
Right.
But some dogs it doesn't. So it stays open.
Okay. Excellent. So Maureen, tell me a little bit about the teamwork between the surgery and cardiology team with these procedures, because it sounds really complicated. What specific procedures do you collaborate on?
This is the only one with the clamp that he places across the mitral valve. I'm always there if he needs help with other things, but usually that's the only one that it's a planned procedure, so to speak. The biggest role I play is that because he needs access to the heart itself. Like it's not one that he can go through the vessel and get access to what he needs to do. So my role is, basically entering the thoracic cavity or the chest cavity for him and then helping hold the heart up. And then that way he has access to the heart. And then he places the implant through the heart muscle. And then I close that little hole that he makes. And then I close up the chest cavity again. So my role is just, I always tell him I'm presenting the heart to him on a platter.
Now, did you need to acquire new skills with doing this, or all of these things are things that as a surgeon that you already knew how to do?
I think, like I always say, surgery is a science of you have your fundamentals, and then a lot of times it's growing from those fundamentals. I did spend some time, with Dr. Orton out of Colorado State, just to kind of like working on a beating heart is just something you kind of need a little bit of comfort level with. And so the first couple that I did with him to get some of the little, we always say tips off, approaching, entering the chest, that part is fairly routine for a surgeon. It's the part of actually just working around the beating heart. And so a little bit of comfort level working with that. Some of the technique is pretty similar to when we place what we call an epicardial pacemaker, which is where we actually place the pacemaker directly on the heart. So some of that skill is the same, but a lot of it was just learning straight from somebody with experience.
And was any new equipment involved in doing this procedure from a surgical standpoint, or did you have really what you needed?
We had to get some more cardiovascular instruments. So it was more just instruments, like we already have the floor and that kind of stuff. So I just had to get some specialized suture material, actually, and then a couple special, needle drivers is the big one.
And Justin mentioned earlier veterinary technicians with anesthesia. Are there other roles that credentialed veterinary technicians are playing during these, and how important are they to the team?
Some of our anesthesia technicians are further credentialed to know what we call the veterinary technician specialists. So they've obtained additional training and test taking for anesthesia. We are a little bit of unique hospital that we have some surgical technologists that were trained on the human side that have come over to the veterinary side, which in their college, veterinary medicine is a subspecialty that they can maintain their credentials from.
Oh, wow. Okay.
And so they're very helpful with a lot of assisting and instrumentation as well. And they help teach our veterinary technicians as well. It's definitely a village.
Yeah.
And Justin, do you have anything to add to that?
Yeah, good technicians make life so much better. I don't have to worry at all about what's going on anesthetically with the patient, because especially with some of our procedures, the patient, we're putting dogs under anesthesia that actually oftentimes have pulmonary edema at the time. So they're in active congestive heart failure. So they have fluid in their lungs at the time that we're doing these procedures.
Which is not good for anesthesia.
That's hard. That's really hard. We worked very closely with the technical staff, and especially when we started doing the decompressions on trying to get and find the most effective effective, safest anesthetic protocol. And, we've done it a few hundred times now, so we have a better idea of exactly what works and doesn't. That was one of the major sort of hurdles to overcome when developing these things.
So, Justin, as you've mentioned a couple of times already, the most common heart disease in adult dogs is mitral valve failure, which the mitral valve is between the top and bottom chambers on the left side of the heart. When I was in practice, management of mitral valve disease really was only medical to really control symptoms, to try to get fluid out of the lungs and things that you'd mentioned a little bit. You're now offering a much newer and actually quite uncommon treatment option. What are the advantages of actually being able to do a mitral valve repair?
The advantage is that they may never go into heart failure, or they may never go into heart failure again. So it could potentially fix the problem.
That's a change.
It's huge.
So if I treated them medically, 100% of them were going to go into heart failure again.
Exactly. So no part of my practice has changed more than the mitral valve talk. Now, when I go in and talk to people about mitral valve disease, I talk about medical management, and then I talk about interventional therapy, and I talk about open heart surgical repair as well, which is offered at a few places in the world now too. And so people do have these options now. Realistically, it's not for everybody because this stuff is really nice and really fantastic, but it's also really expensive. But it is available, which is a major, major shift.
Pets with heart disease can certainly be really sick. How important is the selection and client preparation for doing an interventional procedure like a V-clip?
V-clamp, it's very, very important. There's unfortunately only a select sort of segment of the dog population with mitral valve disease that's really ideal for a V-clamp because of the anatomy, because of the device itself. And so there are certain dogs that just don't qualify because they're too small, too big. The disease of the valve is just too substantial or just won't be easily clamped with the device. So a lot of dogs, unfortunately, get screened out for that particular procedure.
And is there a typical size range for which dogs would qualify?
Yeah. So 5 to 15 kgs is really the sort of sweet spot. It doesn't depend so much on body size as it does on the actual size of the valve. And so that's something that we measure on echocardiography or ultrasound of the heart. And so that's one of the big, if you think, oh, my dog might need this procedure, we'll come in, we'll actually do a pretty precise measurement of that mitral valve to make sure that that's even an option. And then when we go into the procedure, we'll actually do a transesophageal echo. So that means that the ultrasound probe goes down the throat and it sits right on top of the heart. And that gives us a 3-dimensional image of the valve. And we can measure it very precisely then. And if it's not going to work or it's going to be too high risk, then we'll call the owner and wake the dog up.
What is the device actually that you're using here? And is there any chance of rejection?
So we're using a V-clamp, which is made by the Hongyu Corporation in China. It is a metallic device that really, as far as we know, doesn't really carry a risk of rejection. It's very well tolerated once it's in. The problem is more of patient selection, and it can traumatize the valve because it's a piece of metal and it's thin. And so that's the real risk. And you're sort of pinching it together, a diseased valve. There are a couple different valve replacement options actually that are in the experimental phase right now. One by Hongyu and one by Ultravet, and there's another out of Germany. And so, and a couple of those actually are transeptal. So we may eventually, and hopefully relatively soon, be able to completely replace the mitral valve through the vein in the neck. And so that would be sort of the next step. And these things are being actively developed. So, yeah.
Well, lots to look forward to. So, Maureen, I know both of you are committed to teaching and training veterinary residents to become specialists in your respective fields, and you both have training programs at West LA. How important is it for your resident in their training to be involved in supporting in these cutting-edge procedures and working as a team?
Yeah, I think it just fosters that collaborative work ethic. Like I always say, I can't do my job without other specialists. I think it's part of, there's, as a surgeon, they're going to be working it with other colleagues and other specialists. And so I think that's important. I also feel really strongly that we're lifelong learners. The day you finish your residency, still there's so much more to learn.
I know.
I know. When I was a resident, one of my mentors always said, if you do the procedure exactly the same way 10 years from now, then you're not learning, because science changes, we get better equipment and things like that. So I really instill, lifelong learning in them. As surgeons, we're faced with learning procedures that we've never done before, just based on principles and that type of stuff. And so I think it's important for them to one, see me doing a procedure I've never done before, but then also we've had some opportunity for my residents to do procedures that they haven't done. We had an interesting case. Again, as it was a dog with a congenital malformation of its heart vessels, and we actually put in an artificial shunt vessel. Oh, okay. We collaborated with cardio on that one as well. But again, it's just significant learning for my resident to do a procedure not really well documented in veterinary medicine, but just from learning from the human side. As more and more people have pets, more and more people want their pets to have the same quality medicine that humans have. I think that's all part of what we do.
How important is publication of new information that you're learning to contributions to veterinary healthcare?
Yeah, like for me as a specialist, I always feel it's part of what we need to give back to my college.
Right.
Like if I'm engaged in doing procedures and learning new things and that type of stuff, I think that's how we, again, grow as a college. So I just think that's part of what we should be doing to improve our college.
Yeah, publication, just disseminating that information that you've gained and the experience that you've had, I think is really vital. It's become one of the most important parts of my job, actually. It just opens up so many different avenues for communication. For I have people from all over the world emailing me, asking me questions because of the publications that we've got out there. So a lot of the stuff that we're doing with TIER actually grew out of publications that we had made because of the experiences that we've had around the left atrial decompression. So they knew that, hey, they're doing interesting things. They have the capabilities of doing that. Why don't we invite them out here so then they can get involved in this too? So that sort of fosters hospital communications across both academia as well as private practice. So I think it's a really, really vital part of what we do.
We are unfortunately nearing the end of our time together. It has been an absolute pleasure hearing from both of you and learning about the wonderful programs you're offering at West LA. My final question is, and I'll preface this by saying that as a specialist, you finish your residency and you think you're good to go and don't need anything else. And then at some point in time, sometime after that, you want to continue to learn and grow. So what advice do you have for, I'll say, early career veterinary specialists to continue to grow throughout their career?
I think it's a tough question. I mean, I still think it's just that wanting engagement. I see it's all environment. Like I think West LA is a hospital that the environment is all about teaching and learning. Yes. So, just kind of, when you go out there, find that hospital that's a good fit for you. That's you can especially collaborate with other specialists because, as we become more and more specialized, you're going to need the help of other people. Right. So I think it's just really finding that good fit. And then, again, when my residents leave, I'm always like, just keep learning, go to your conferences, go to different conferences and that kind of thing. So
I think the biggest piece of advice I guess I would have is learn how to be okay not knowing something.
Oh, good advice.
And that sounds really obvious, but I was so bad at that when I came out. I felt like since I was the expert now, I had to know everything. I had to know. Yeah. I had to know I had to get the guy with all the answers. And that is impossible, number one. But number two, it closes things off. You become closed off because if you already know, you can't be taught. And so, that is, I think, that's something that I've had to become okay with. And I'm much more comfortable now saying, I don't know. Let's figure it out. But I don't know.
Well, thank you both so much. Thank you for this wonderful, innovative work that you're doing and bringing these programs to West LA. Thank you for your teamwork and training the next generation of veterinarians and veterinary specialists. And I really just appreciate both of you so much and know that our listeners are going to get a ton out of hearing from you as well. So thank you both for everything that you do.
Thank you, Marie.
A pleasure.
Thank you for listening to today's episode. We hope you enjoyed it and learned a few helpful tips. If you haven't already, I encourage you to subscribe and listen to our previous episodes to hear the many valuable insights and lessons from our past guests. Don't forget to leave a review for today's episode and share with friends. Make sure to follow VCA Animal Hospitals on LinkedIn, Facebook, and Instagram to stay in the loop. For more inspiring stories, visit our website at vcavoice.com.